My name is Bakita Kasadha. On behalf of the Nourish-UK study team, I'll be presenting the preliminary findings from this study. The study is funded by the National Institute for Health Research, Research for Patient Benefit, and is led by Oxford University. And we have an advisory panel, which includes mothers living with HIV, HIV physicians, and HIV organisations. Nourish-UK is a qualitative study aiming to understand how new mothers, pregnant women, or birthing parents living with HIV decide how to feed their newborn babies in the UK. We will use this learning to develop a new infant feeding and HIV section on the healthtalk.org website and hopefully inform future policy. Within the UK, over 800 women with HIV give birth annually, and within the context of HIV, infant feeding guidelines vary across the world. Now, BEVA, the British HIV Association, develops all treatment guidelines for people living with HIV in the UK. And in 2018, it updated its guidelines to say that mothers with HIV should be encouraged to formula feed, but should be supported to breastfeed if they are virologically suppressed and are willing to have additional blood tests. Mixed and combination feeding is not advised. The majority of women living with HIV in the UK are of Black African ethnicity, and across sub-Saharan Africa, breastfeeding is advised within the context of HIV. All our study participants were required to be HIV positive, pregnant, or have a baby under 1, and we recruited them through HIV clinics, HIV organisations, and through snowballing. Since submitting our abstract, more participants have consented to take part in the study. In total, there have been 36 mothers and pregnant women interviewed, and the majority were in their 30s. Most participants were born in an African nation and were of Black African ethnicity. 31 of the 36 participants had been diagnosed with HIV before their most recent pregnancy. When asked if they could afford to cover their basic needs, only half of our 36 participants said that they were able to afford basic expenses either all or most of the time, and the majority of participants were in relationships. There were 8 pregnant women, including a participant who was pregnant and had an infant under 1 year old. Half of them stated their intention to breastfeed, while some were undecided or were planning to formula feed. Participants shared all their reasons for their current feeding intention. The wording in bold was the most common reasons given by participants, and the majority of pregnant participants who were undecided or wanted to formula feed wanted to remove all risk of HIV transmission. The majority of pregnant participants who intended to breastfeed cited health benefits for themselves and baby, as well as bonding and cultural expectations of motherhood as their main reasons. The majority of participants had already given birth, and of them, the majority had chosen to formula feed. As with the previous slide, the wording in bold are the most common reasons given for the feeding decision. The majority cited removing risk of HIV transmission as their main reason for formula feeding. A minority shared other reasons, which included formula feeding, providing an opportunity to share feeding duties with their partner. One participant had intended to breastfeed, but her twins were born premature, which led to her formula feeding. Combination feeding is not advised, and 2 participants had intended to breastfeed, but reported that their babies were given formula on the maternity ward, and this was done shortly after birth by a clinician and meant that breastfeeding was no longer an option. Similar to the pregnant participants, the participants who had breastfeeded were motivated by health benefits, bonding opportunities, and cultural expectations. Only one participant shared that her partner wasn't aware of her status, and that was her main reason for breastfeeding. In terms of the themes, participants reported inconsistent infant feeding information from healthcare providers. So this participant spoke about the fact that she was in a meeting with her pediatrician and also with a midwife, and they were offering different support and advice. The pediatrician had said that had breastfeeding not worked, that she shouldn't be very stubborn with it, especially as, and she also mentioned that breastfeeding can lead to malnutrition. And the midwife who was also in the meeting responded, well, come on now, it's not that common. Participants reported a limited awareness of the updated infant feeding guidelines. And for this participant, she said, I was just made to believe that it was a high risk of transmission and that it was, you know, just a no-go. Half reported not feeling supported to breastfeed by their HIV clinicians, and 2 recalled their HIV clinicians actively discouraging them from breastfeeding. Now, this participant produced colostrum, but she had not produced milk, and the maternity ward advised her to formula feed, which removed her option to breastfeed in the future. She remarked that the healthcare professionals on the maternity ward didn't have HIV training, and the organisation that she'd called for breastfeeding support was not open out of hours. Regardless of their infant feeding decision or intention, participants emphasised the importance of their healthcare professionals and partners supporting them in this decision. And this participant says that if one of them, her husband, her mum, or HIV physician had shut her down and said that it was not a good idea, she doesn't think that she would be as confident as she is now. To conclude, the changes in the UK infant feeding guidelines are currently not reflected in the experiences of women interviewed in this study. There is a significant informational need among women living with HIV around their infant feeding options. It is clear that some healthcare professionals are either unaware of the updated guidelines or are unwilling to implement them in practice. And specific training regarding BEVA's infant feeding guidelines are needed for all healthcare professionals who support new mothers and pregnant women with HIV in order to empower them to make informed and supported choices. Thank you so much for listening. Thank you to our participants, our advisory panel, our recruitment channels, and to the International Workshop on HIV in Women for this opportunity.